Hello, it's Kris from Memorial Sloan Kettering. And I'm probably ill-advised to do this, but I'm going to do it anyway. And that is to try to jump into the ongoing discussion about adjuvant versus neoadjuvant therapy for resected or resectable non-small cell lung cancers. The controversy exists. And why does it exist? You know, there's a long tradition of doing surgery upfront. And clearly many people are cured by surgery. And then that's really the basis of this. People that are practicing now, they were trained by people that grew up with that as a mantra. And those people in turn had their mentors tell them that getting the patient to surgery was absolutely critical. And there's no question that it is. But things have improved. There are additional approaches, all including surgery, frankly, for resectable patients that need to be considered. I think my position in 2025 is that you need to make the decision based on risk. And the risk is based on clinical stage and by and large on tumor size. And I think the important thing is that in each and every patient, other than with the tiniest tumors, which I'll speak about later, there needs to be a multidisciplinary discussion, not necessarily a tumor board, but a discussion about what you can do with more therapy beyond surgery, either before or after. So I'd like to just talk about some kind of myths and realities here. I think the first one is people keep saying, oh, we need a randomized trial to do this. Well, the truth is, number one, there is no randomized trial in the modern era. There's some older trials that have done that, the so-called SCAT trial, done many years ago by investigators from Barcelona. And there's no data, and there's not likely to be any data. And the reason is and you can't go by the data that's already out there, because adjuvant and neoadjuvant, they're two different beasts. Neoadjuvant therapy, the clock starts ticking at the time the patient is consented. And for neoadjuvant, the clock starts ticking after a period of time has elapsed after surgery. So by the nature, it's apples and oranges. Also, please note that no matter who this is, not all patients turn out to be resectable, so there's that dropout. But in the adjuvant cases, those cases are already gone. The ones that had more advanced disease that was not appreciated, where more advanced disease was seen at the time of surgery, those people are included in the neoadjuvant, but not in the adjuvant. The other point, and this again is another myth, there's this idea that if you spend any time giving neoadjuvant therapy, that you're somehow going to jeopardize a patient's chance for a long-term outcome. Well, the first thing is, when you actually look at the data, people that have do not go to surgery, many of them, again, have more advanced disease than was appreciated. And secondarily, many of them have unappreciated metastatic disease. So to put those people through surgery only to discover metastatic disease later just does no good. Also, this idea that people develop a brain metastasis or a liver metastasis during the 6 or 12 weeks of adjuvant therapy is also not really based in reality. People have micrometastatic disease that we have not detected. And the other issue is, if our therapies fail, then we do not have any effective therapy to control systemic disease. So given these people are in a very poor prognostic group, and I'm not sure how much surgery helps those people when our systemic therapies are ineffective, and sadly they are every now and then. The other issue is, we're subjecting them to some kind of risk. Well, you know, the risk of neoadjuvant and adjuvant therapy is the same. Let's pick on a checkpoint inhibitor. The risk of colitis, I don't think it's any different neoadjuvant versus adjuvant. They can be managed, frankly, either way. That is not an issue, but that keeps being brought up as well. And the last thing is the issue of the nodal status. Well, the truth of the matter is nodal status is really hard to assess. We can approximate it, but we can't be sure until we do surgery. So I think the critical thing is that you base your neoadjuvant decision based on tumor size. Sometimes you have clear data that you have disease, but the absence of disease you really can't use because you can't be sure. Remember, these nodes are sampled, they're not dissected. Now, the last thing is you still can benefit if you can have an R0 resection despite the persistence of disease in lymph nodes. And we have seen cases now, we've eradicated the tumor in the primary, there's still some in lymph nodes, and patients can have long-term benefit. The key is an R0 resection. So there are many, many things that sway people, but the most important thing is that you talk these cases through and think about using neoadjuvant therapy for anything other than a small tumor. And I'll talk further about the advantages of neoadjuvant therapy.